So I'm Mr. Shashank Gurjar and I'm a consultant colorectal surgeon. I work at the Luton Dunstan Hospital, which is my primary NHS base, and I do my private work here at 1 Hatfield Hospital. An anal fistula, or fistula in ano, is a small tract that forms between the anal canal and the surrounding skin of the anus. It's usually the result of infection or following surgery to drain anal abscesses. The commonest symptoms are bleeding or discharge of pus when going to the toilet. It may be associated with pain when passing stools. So fistulas can affect anybody. They're typically seen in the 3rd or 4th decade of life and are predominantly seen in men. Over 90% are due to intersphincteric space gland infections. There are associated conditions which include Crohn's disease and tuberculosis. Hidradenitis suppurativa, which is an infection of the sweat glands of the skin, is also associated with fistula formation. Much rarer causes include trauma, cancer, and foreign body perforation. The treatment of an anal canal fistula is entirely dependent on the nature of the fistula and its relationship to the external anal sphincter. The sphincters of the anal canal are split into two, namely the internal sphincter and the external sphincter. The importance of the external sphincter is that it is responsible for keeping you continent. We classify fistulas in terms of simple or low fistulas, and these are very easily just laid open, or complex or high fistulas. This latter group require careful preoperative planning and may need 2 or more operations to get definitive healing. The clinical assessment of an anal canal fistula is very important. As a colorectal surgeon, I would perform a careful digital rectal examination to assess the perianal area and look for an external opening, which would raise suspicion of an anal canal fistula. I would then want to palpate the tract carefully to assess the nature of the fistula tract and also perform a digital rectal examination to locate the internal opening. If I would suspect a high fistula, an MRI scan would be mandatory to accurately work out the anal canal anatomy and look for any other supplementary tracts. Often a flexible sigmoidoscopy is performed to look at the left colon and rectum and ensure that any other causes have been ruled out. If the fistula is low, it can simply be laid open. This means that the tract is excised fully and a fistulotomy is performed. I would only do this if I was happy that there was minimal external anal sphincter involvement and that continence would be unimpaired. If the fistula is high fistula, I would have to initially place a thread or seton which would act as a drain to help reduce the risk of infection and allow the tract to fibrose and mature. A few months later, a more definitive operation could be considered. Options at this stage would include laying it open if the seton has migrated down over that period. Alternatively, a fistula plug can be placed, which is a collagen-based implant which can help close the tract. An alternative operation is the lift procedure or ligation of the intersphincteric tract. This involves dividing the fistula between the 2 sphincter muscles and thereby terminating its pathway. A newer operation involves using a laser to obliterate the tract, and this is called the Phylac procedure. Some surgeons still use the collagen paste technique, but this has been shown to be less effective. It's fair to say that no single procedure works for all cases or can be considered to be 100% successful, and common success rates are quoted up to 60 to 70%. Most of these procedures can be performed as day case procedures. The patient would come in and undergo a general anesthetic, and then the operation will be performed. We will then discharge them on analgesia, antibiotics and laxatives. Most patients would probably require a week off work. As I said earlier, there is no single procedure that works in all cases of complex fistulas. Therefore, the quoted success rate of 60 to 70% is a fair assessment. Fistulas are a common problem, and the key to success in treatment is to convert a complex or high fistula into a simple or low fistula. Once a low fistula has been treated by the laying open process, success is 100% effective. The more complex fistulas may require 1 or 2 procedures, and they do carry a higher risk of recurrence. I accept patient referrals directly via One Hatfield Hospital or via the GP service. Additionally, my secretary will take referrals for all patients via her direct contact number, which is 07506 589 070.